Kia ora koutou. Welcome to today's webinar on how AI can improve clinical workflow and experience for clinicians. I'm Rebecca Macbeth. I'm the media editor at HIMSS, and I'll be your facilitator today. I'd like to thank InterSystems for sponsoring this webinar. So we have a fantastic lineup of panelists today. I'm going to ask each of them to just briefly introduce themselves. So joining me today, we have Dr. Emmeline Ramos. Welcome, Emmeline.
Hi, Rebecca. Thanks for having me. Hi, everybody. My name's Emmeline Ramos. I am a physician executive for InterSystems Asia Pacific.
Thanks. And Dr. Ryan Radecki.
Yes, hello, everyone. I'm Ryan Radecki, and I'm an emergency physician down here in Christchurch, and I also work with Health New Zealand's AI Lab and their HealthX initiative.
Thanks, Ryan. And CK Jin.
Kia ora, everyone. I'm CK. I work as a clinical director for Health New Zealand's AI laboratory, and I'm also involved with the HealthX initiatives as well.
Great. So first we're going to have presentations from each of the panelists, and then I will be opening up the floor for questions. So do keep those coming in using the three dots button at the bottom right-hand corner of the webcast player. So first up, we have CK. Thanks, CK.
So kia ora, everyone. So today, just kind of want to focus more around kind of how Health New Zealand is approaching AI. I see it kind of being used in three broad categories: so risk priority scores, machine vision, and generative AI. I think a lot of attention is placed on generative AI. Work is actually occurring in all these areas. We will talk through each area, provide an example of how AI is or will be used in Health New Zealand to support clinical staff. When it comes to risk and priority scores, these are typically calculating the chance of an event occurring based on structured healthcare data. Health New Zealand, like other healthcare organisations, is facing similar challenges of limited resources and growing demand. These algorithms aim to help make evidence-based and data-driven decisions to help clinicians focus in their attention. Such algorithms were used in the COVID response, and algorithms for other use cases are being developed. Fracture risk algorithms are being developed to identify individuals who are at high risk for additional support and treatment. Risk scores are being developed to facilitate the screening programs to provide customized screening pathways based on individualized risks. As the country's health data becomes more centralized and standardized, I anticipate that more of these algorithms will be developed off these national data sets. I guess machine vision, or the use of AI to interpret medical images, that is an area that is somewhat underutilized within Health New Zealand. However, there are plans to explore its potential use in areas like radiology, where AI can assist clinicians in identifying potential pathologies more efficiently. Such tools were first developed around 10 years ago, and a large number of commercial products are available with good evidence being generated internationally. Radiology will be a specialty where we will see more forms of this AI being adopted more widely, and several tools are being planned for trials and implementation in the near future. The first example is around the use of AI for general radiology exams, so the likes of chest X-rays and CT brain exams. Such tools, they're able to detect over kind of 100 different findings, and if based on the vendor publications, often they are meeting or surpassing human abilities. Must emphasize that this is vendor-sponsored research, and that I'm not advocating for the replacement of clinicians, just that the technology has reached this level of performance and greater trust can be placed into these tools. These tools will be primarily used as a diagnostic aid, suggesting potential diagnosis for radiologists. However, this will not be the only way that these tools can be used. The same AI systems could be used as an initial screening tool to understand what potential pathology is contained in each exam. The order in which radiologists report the exams can be reprioritized based on the AI findings, so pushing exams with critical findings to the top. And by doing this, would improve the timeliness of decision-making and support better patient flow. I think in other areas, computer vision is also being explored for use within screening programs. breast screening and diabetic retinal screening are two areas where AI is being considered. These tools are being considered for use in kind of different ways. For retinal screening, we're exploring to see if these tools can identify images with no pathology, reducing the need for human involvement. For breast screening, we're exploring how these tools can be introduced into the screening pathways to improve detection rates and reduce resource requirements. Under both use cases, there will be some degree of automation, which will require greater evidence prior to implementation. And as such, both are under research currently. So I guess when it comes to Gen AI, I think it has received quite a significant attention in general media as well as the health sector. Health New Zealand, we are actively looking or exploring to see how these tools can be used, and a number of use cases have been identified. I think ambient scribes, it's one of those Gen AI tools which many will be familiar with. These operate by actively listening to a conversation between a patient and their clinician. It will actively transcribe and summarize that conversation into a medical note. This helps clinicians reduce administrative burdens, reduce the cognitive load of having to remember a long conversation, allowing them to focus more on the patient in front of them. I think these tools, they've been quickly adopted within the primary care sector, and Health New Zealand is also looking to adopt these tools more widely as well. I think these tools, they've been initially trialed within the ED setting, and they've demonstrated good improvement in efficiency, and I think further rollout is anticipated. Further information around kind of how around its expansion and will be announced in the coming week. However, it is also important to highlight that Gen AI is also being explored for other use cases as well. Gen AI is being applied to clinical guidelines, internal policies, and procedures to facilitate access to this information for clinicians. The aim is to help clinicians retrieve relevant information in a timely manner. I think we're also exploring how Gen AI can be used to generate other forms of clinical documents, so things like discharge summaries. We're attempting to do this by using existing and routinely collected information and to support some of our junior staff around kind of creating these documents. Yes, just from, these examples that's provided, we can start to see that AI is beginning to be implemented in Health New Zealand. I think these tools offer enormous potential to have the ability to transform the way that healthcare is delivered, support our clinicians as well, and making a smarter, safer, and more sustainable healthcare system. Kia ora, everyone.
Kia ora. Thank you, CK. Really interesting. And to the audience, remember to keep your questions coming in. You use the 3 dots button in the bottom right hand of the screen and select Ask a Question. And yeah, if you need to see information about the speaker panel, if you've just joined us, at any time you can use that same 3 dots button and select the info option. So next up, we're going to hear from Ryan. Take it away.
All right. Thank you, everyone. I'm going to talk a little bit about, so thanks, CK, for telling us about where Health New Zealand is at. And I'm going to take a little bit of a tour around the world and see where other people are going with their impact of AI on clinical decision-making. And I'm putting that kind of in the context of that this is sort of the end of classic doctoring as we know it. It's a whole new sort of generational shift in how we interact with information and patients and the tools that help us be doctors. And it's going to be interesting to see how we fit in. Because we've all seen some of these graphs and tables talking about the MedQA examination and that LLMs, the various off-the-shelf ones, can pass these medical standardized examinations with 90+% pass rates, way higher than the average clinician can do on these sorts of exams. And then you have even specialized medical models that are even achieving 100% pass rates on these tests. And they take these LLMs and they put them in the hands of clinicians. And great. So clinicians improve because they have access to the LLMs. But the dirty secret, to some extent, is that the physicians are still holding the LLMs back in some of these cases. And you can see that there have been a couple experiments out there done where GPT by itself has outperformed the clinicians, despite access to GPT resources as well. And so the question is, and what we're seeing around the world, is people trying to leverage the power of LLMs and find ways to partner with clinicians to make clinicians better doctors. Some of the examples out there that these are things that are either in production or about to go into production are things like Epic Systems and their Comet sort of initiative. And this is a thing where they took, Epic has a huge installed base in just the United States and around the world. They've data mined all these systems to make a huge database that has all this clinical information and their sort of the progression of these patients through time, and they've broken it down into tokens, just like large language models break text into tokens so they can predict the next word in a sequence. If you take a patient and you turn them into tokens, you can predict the next token in a sequence, and that token can be a medical event or something like that. And they use this on the patients to try and predict their long-term health outcomes. And they've done some academic articles talking about that, and you can see that they can, as it gets closer and closer and closer to the event, the likelihood that their prediction for specific types of medical events improves. And this is better than any just this off-the-shelf sort of generalized LLM training off the Comet database. It's actually better than a lot of the individual sort of machine learning models that try to predict these in their narrow use cases. And this is being deployed out to potentially all the Epic customers who want to subscribe to something like this. And it's going to be a tool in the hands of clinicians to try and add this information to leverage it to improve the care for patients. They have other tools leveraging, again, that data lake, that cosmos that they have, to use patients, this lookalikes, best care choices, finding other patients that are like the ones, kind of like a digital twin. So this is another example of where they use and leverage AI and machine learning to match your patients to those other patients and allow increased collaboration between doctors, increased, and in theory, increased successful treatment for patients, especially for rare conditions where it might be hard to track down a patient that's just like yours. But they have this huge data lake of hundreds of millions of patients, and that's going to be in the hands of clinicians as well, people who use the Epic platform. Places like Stanford have built something that's kind of like that. And it's this idea of where you have data warehouses and you have all the history of all these different patients and how they turned out. It's called real world evidence. And they have a company called Atropos that's made something called Patients Like Mine. And this is a real thing that's already in deployment at the Stanford institution, where they can get this prognostogram. You can ask a very specific question to their artificial intelligence matching algorithm, basically. And it'll combine both the evidence from contemporary guidelines and treatment protocols with the responses of previous patients to that same sort of treatment, and it'll come back and give you treatment recommendations specific to your patient to help treat them as well. There's a beautiful example out of Kenya of a place called Penda Health. So clinicians make mistakes all the time. There's lots and lots and lots of examples of how clinicians overtreat with antibiotics. They miss things when they ask questions. And one of these interesting things that this institution has done using OpenAI as a partner is they've actually deployed a platform in their urgent cares where it follows along and reads their notes for them. And in the background, it matches up whether the notes in the plan and the assessment are actually concordant with the guidelines for the treatment of that condition in that country. Specifically, they focused on things like gastroenteritis because this is sort of a rural setting, Kenya. And this is an example of a place where a clinician had gone ahead and prescribed metronidazole for gastroenteritis. Most gastroenteritis is one self-limited or viral, and antibiotics either prolong the carrier state or don't help at all, and then you just have side effects and extra costs. And they actually found that when this AI sort of monitored them in the background, they actually improved the care, and they could demonstrate that in a statistically significant fashion. And this is just one example of how this is already in use in helping clinicians improve the care for patients. You might feel a little bit wary about AI looking over your shoulder and and offering this sort of advice and guidance, but in the end of the day, what really matters is how the patients are doing. And this is an example of where patient outcomes are improved by this sort of technology. There's another company. We talked about AI scribes and the potential that they are going to be everywhere. And you probably are. If you've been to a GP recently in New Zealand, you've probably been asked, if can I use my AI scribe to listen in and help me with my documentation. This company, Open Evidence, has taken this to the next step with their AI scribe product. Open Evidence is well used throughout the United States as sort of a resource, sort of a textbook, a lookup, a medical knowledge base that's based on a large language model. And they have built an AI scribe that uses that again with the content of your clinical interview, and it inserts within your assessment and plan suggestions about how you could better care for your patients, making sure that it's guideline concordant. And this is available for clinicians to use right now all around the country, U.S. only. And then taking that extra step forward beyond just sort of the clinician, the AI looking over your shoulder, the Google DeepMind has developed a product that is an semi-autonomous AI agent that is a chatbot that has created guardrails so that it doesn't come up with an assessment and plan and doesn't respond to a patient and their problem with suggestions about how the treatment's going to go. It just collects information and then provides it to a physician in the loop, a physician who can review the plan for further refinement or development. When they've tested this against nurse practitioners and physician assistants, they've tested it against primary care physicians, and they found that the artificial medical intelligence explorer, as they say it with the G for the guardrails, actually can increase, is better at diagnostic accuracy, leads to better diagnoses, leads to better plans than all of these different people, the different clinicians in their comparison. And what it looks like to one of the clinicians in the loop is that they get this beautiful pre-formatted output, a clinician cockpit where they can sort of review all the information that's been gathered and either sign off on the assessment plan or take control of the encounter itself. And this is another thing that's been operationalized by Google, and they're deploying this in a couple different research settings. Not quite here yet, but this is the future that we're looking for. And the question is, as these evolutions move forward, what's next for clinicians? And I think the biggest question that we're going to be talking about over the next year or so is how do we evolve our practice to incorporate these tools? Where do doctors add value to the artificial intelligence? It's which tools can we access and use to improve our care? And I suspect that our next speaker is going to actually give us some real world examples of how that's being used.
Great. Thank you, Ryan. Well, we've got lots of questions coming in. So both the presentations so far have sparked off lots of thoughts, which is great. Keep those coming in using that 3 dots button and select Ask a Question. So, and also if you just joined us and you want to see information about the speaker panel, then you can just use that same 3 dots button and select Info. I think next up we have Emmeline. Have you got your slides coming up there, Emmeline? And we'll pass over to you.
Yeah. Just coming up now. Can you guys see that? I'll put that in presentation view.
Perfect. Thank you.
That's okay. All right. Fascinating discussion so far. Thank you very much for the local perspective, CK and Ryan. It's amazing tour of what's currently in the Gen AI landscape and how it could potentially be used in the future. What I'd like to go through now is just a little bit of a real world use case and an actual implementation of generative AI within the customer side. So I work for a company called InterSystems, and we have a generative AI-native electronic health record called IntelliCare, which we launched a little bit earlier this year. And we actually went live with a customer in Indonesia called EMC Healthcare, and that's a group of 8 hospitals in Jakarta. And went live with our IntelliCare product. So it was a fairly quick adoption from our launch in April to a customer going live in August. And just to tell you a little bit about the product so you can understand what functionality they're using. So we have, I guess, three main aspects to the product. There's the AI scribe, which everybody's very familiar with in New Zealand. You can record your consultation with the patient, and then you pop it into the EHR, and it will go through that transcript for you. We've gone a step further with IntelliCare in that the AI assistant will actually pick up and turn free text information to structured information. So it will pick up, things like diagnosis, allergies, and alerts, and it will turn that into structured data, code data, be it SNOMED or ICD, and it will use that to populate the EHR. And it will also take what we call orders, so a lab test or an imaging request, or a bit of nursing care. It will pick that up from the free text, and it will automatically turn that into orders. So that the clinicians can go from having to type in and look for a full blood count and a chest X-ray to actually the AI assistant picking that up and allowing them to use that for ordering. And then there's this other aspect to the product, which is like Ryan described, a chatbot inside the EHR. And when a clinician opens a patient record and they access the AI assistant, what actually happens is we have if you like, a RAG model in background. We have an API to a large language model, and we send a lot of clinical data in a little space in the EHR, so that the large language model via the API can pass through that patient information, and then the end user, the clinician, can then use the chatbot to ask the LLM anything they want about that patient. So it's a RAG model for data retrieval, and what it does is it allows the clinician to, instead of having to navigate around the EHR and look for patient information, they can just ask the chatbot information. And what I have is a data set from the first 4 weeks of use across the 8 hospitals from our customer in Indonesia. And I just want to go through, what if a doctor in hospital has access to an AI chatbot that can tell them, whatever.
Kia ora. Apologies about that. We just had a short technical problem there, but we are back on board here. So we will continue on with Emmeline's presentation, and you can continue to ask questions. They are absolutely rolling in, so we're going to have plenty of time for Q&A as well, which is going to be great. So we will pass back over to Emmeline if you're ready there, Emmeline. Thanks.
Okay, can you guys see my presentation?
We can, thanks.
Yes, okay. I think I was up to what the doctors asked for, and I think I've gone through the list. I just want to go through quickly, I mean, for me, the interesting things that the data showed in terms of, prompts that the end users submitted to the large language model about the patient. And I guess the main message is that doctors tend to use the AI assistant predominantly for data retrieval, and the commonest things that they look for, drug history, especially 2 particular things. So they especially want to know about antibiotic treatment and vaccinations, and this is across all clinical specialties. So these are 8 large private hospitals in Jakarta. And they have, the breadth and depth of hospital clinical specialties. So everything from, orthopedics to generalists to pediatricians to cardiologists. So they mostly want to know about drug history, antibiotics, and vaccinations. And they mostly use the AI to look up things like weight and vital signs. Even though, surprisingly, the patient's weight would actually be on every screen in IntelliCare, because it is actually on the patient banner. The doctors tend to try and use the AI as a shortcut to just give me the information that I need, which is unsurprising, particularly for busy specialties like intensive care and emergency departments. the majority of users tend to prefer using their own free text prompts. So we do have what we call system prompts or site prompts, which we have set up in conjunction with the customer product team to give the doctors a shortcut so that they don't have to type these things out. So, for example, a patient summary or, comprehensive medical history or something to allow them to pass through transcription. But, I have to say the majority of them, so 70% of the prompts that were submitted were free text prompts. And these are free text prompts that the end users preferred to type manually rather than use the prompts that was set up in the system itself or at site. For free text prompts itself, the average number of words per prompt is about 7. So it's actually pretty short, and the median number is 4. So effectively, it's give me the patient's vital signs, or give me the drug history, or give me the latest lab results or imaging results. And interestingly, a surprising number of end users greet or thank the AI. So they would say thank you, or they would greet the AI hello or hi, or they would say please, which I think was quite nice. So yeah, that's just a quick review of the data set that we have from our most recent go level of our product, and we will continue to monitor this data coming in, of course, from our users of IntelliCare.
Great. Thank you so much, Emmeline. So interesting to see, how clinicians actually use it when they have access. Quite a unique data set, I think you presented on that. So we'll go into questions. The first one, I think, is going to be a question for you, CK, is about, is MedSafe currently regulating any of the AI tools that are used for diagnosis in New Zealand?
I don't believe that the MedSafe is kind of taking on this role at the moment. In terms of the regulatory environment for AI, at the moment, it is essentially trying to draw upon existing legislation, so Health Practitioner Act, Privacy Act. I am aware that the Medicines Act is the repealed Medicines Act that will contain a section on AI, but I think it will be framed within that software as a medical device lens.
Yeah, I think that it's due to be sort of drafted by the end of the year and then introduced next year, as I understand, the new Medicines Act. So it'll be interesting to see how they tackle the questions around AI. I've got one, this might be for starting with you, Ryan, which was about just saying some people don't like using generative AI tools for note writing because they find that the clinical writing time actually helps with their clinical reasoning, and that this takes away somewhat. Are you using a scribe tool? Do you have any thoughts around how it assists you and enables you, as opposed to takes away any of your time for reasoning for the patient?
Yeah, I mean, scribe tools are just in their infancy. In Health New Zealand, there's only been a couple approved for use, and it's only been a couple months since they were approved for use. There's very, very rarely will you see people still using them in Health New Zealand at this point, but that's going to change rapidly, I think, in the near future. There was actually a really good discussion at the American Medical Informatics Association conference last year about this exact topic, and sort of like the idea that writing is thinking, and that people, after their clinical encounters, that going through the writing process really helps them frame. They've practiced this. That's how they were trained. That's how they worked. That's how their brain is. It helps them go through the problem and frame the problem and the treatment. And I think we're still learning what the sort of, if there's going to be de-skilling effects, or whether we're going to adapt and become better doctors with the AI scribes itself. We're going to have to find a different way to mitigate this issue. But that's definitely an active area of research, and it's absolutely a legitimate question and concern that's that they're all still thinking about.
What about you, Emmeline? I know you're a doctor by trade as well. Do you have any thoughts around scribing tools and how they add or might take away from?
Look, I can give you the perspective of some of our user base who are actively using the AI scribe within IntelliCare, and the majority of them do find it incredibly useful. And I totally agree with Ryan that, the act of actually writing down your conversation with a patient helps with the process of coming up with, an assessment and a plan. But I guess increasingly now we're finding that, the output from large language models in terms of the output of a clinical consult needs some editing. So in some ways, it goes from thinking time by typing stuff in as opposed to thinking time by editing the output from an LLM. And that's certainly the kind of feedback that we've had, in that because you can't really think and type at the same time. I don't know about you, but I type everything in, and then I review what I've typed in it, and then I would think about, okay, is that what I want to represent my thoughts or my analysis or my data? Is that what I'm trying to say? And certainly the feedback from some of the clinical end users that we've discussed is that actually they find that they have more time to think about the consult and the plan for the patient, but less time with typing. And this thinking time they would try and formulate, but by actually just doing some edits to the LLM output. Because we have when we built IntelliCare as a product, we do try to stick to safe and responsible AI principles. And one of the things that we were really keen to do is to ensure that you hear this term of human in the loop, and that we don't automatically allow the AI to copy and paste stuff into the medical record. Of course, there has to be a human who would review that output and put it in the medical record. So this concept of reviewing what the LLM has produced allows them to make corrections and think about whether or not these are the kinds of investigations they really want to order, and is this the actual diagnosis that they want to put in for the patient.
Yeah. I imagine clinicians process information differently as well, so it's not going to be uniform. Another question is about scribes, and they're just asking if any of the speakers know or use AI scribes at the patient bedside. We obviously mentioned that sort of GPs people using them in clinics, but they've given an example of like a social worker taking a psychosocial history, or a mental health clinician taking history, and more in that kind of bedside situation. Is that something you know about, Ryan, perhaps?
We've tested them in the emergency departments within Health New Zealand for sure. So, as far as like the non-clinician aspect, I'm not specifically familiar with anybody doing it, but I can't say that just because I don't know about it that it's not happening in a pilot somewhere. It's a big country.
Yeah.
I don't know if CK might have any further insights.
I think with the AI scribes, it is being tested in quite a number of different kind of settings by different professionals as well. So allied health all the way to kind of clinicians too. So there is quite a wide range of user bases. I guess it is still quite in early days. We are starting just to try to kind of roll these out only within the last maybe kind of couple months, or the process to roll them out has only started in the last couple of months. So with a bit more time, I think we will get more evidence to kind of understand where it's kind of most beneficial, what kind of user base these tools more suitable for as well.
Yeah, another one of the questions on a similar line, just saying, the word clinicians is not just doctors, and they're interesting on thoughts about how AI functions work for nurses. I know that in the primary care setting where they have had high adoption, there's certainly been the nursing staff are also using the scribes. So you're saying within Health New Zealand as well, there are some nurses as part of the pilots.
Well, I mean, if you think about our AI scribes, it's about documentation burden to some extent, and we're looking at workflows where the burden of actually, recording it and copying and pasting it, and the level of integration, whether there's a time benefit to that and a cognitive benefit to that. So I think there's a lot of use cases yet to be discovered for all the different professionals involved in healthcare, and we're absolutely opening and we're looking at all of those, not just clinicians, not just narrowly physicians, the whole scope.
Someone else is asking about saying they're interested in Māori models of healthcare. They're just saying they presume most of these examples are addressing physical health needs, and rather than other areas of health. And just wondering if anyone has any thoughts on how these might be used, or if they are being used. They've given an example of taha hinegaro, taha wairua, and taha whānau, so addressing your spiritual and family and other things that make up your holistic health. I imagine it's probably too early. It's only pilot stage in New Zealand. But if any of you have any thoughts on how AI might be able to also capture that kind of information about a person.
I guess this could be somewhat related. I think one initiative that's kind of been commissioned by Health New Zealand is a mental health application called Groove. Within that application itself, it is designed to provide mental well-being kind of content that is that was developed with the Te Whare Te Papa kind of mental health framework. Apologies if I have gotten that a bit incorrect. However, kind of the evidence that's part of that application itself has been curated through kind of a clinical governance group. Only the kind of the clinically relevant, safe content has been uploaded into the application itself, and how the language model then interacts with that information. It's only acting as like an information retrieval, so it will only bring kind of relevant information based upon that user's query back. So I don't know if that kind of targets the question that well, but there are ways that you can kind of apply Gen AI into specific kind of context, specific bodies of information to get that more culturally appropriate responses.
Great. Thank you. This one I think is for you, Emmeline. That said they're curious if you have any use cases where a radiologist could utilize IntelliCare in their workflow to help generate structured reports, provide prior reports, patient history summaries, as well as a chat bot to ask questions on those. This is obviously a radiologist, I presume, asking that question. Do you have any thoughts about that?
That's an interesting one, and there are certainly no shortage of AI integrated products into a radiology information system, for example. The IntelliCare is live in this hospital across all specialties, so any clinical specialty, and the customer has chosen to limit it at the moment to physicians rather than nurses or allied health. Certainly from a general data retrieval perspective, radiologists don't just, I'm not radiologist myself, so I'm assuming radiologists don't just look at a scan and type in the report based on the scan. They would actually look at the patient's medical record to help them, identify what this little shadow is, or to produce, an appropriate report. And, certainly a radiologist can use the chatbot to produce a good patient summary to aid them in producing that imaging report, and to ask them things like when was the last time this patient's had a CT abdo, for example, or one of the prompts I've seen particularly from intensivists is give me any abnormal imaging that this patient has had in the last 5 years, for example. So these kinds of prompts would be useful for a radiology use case like that, Rebecca.
This question is generally about AI and if you're using it for health reasons. So they're saying, how do we make sure that the information that it's drawing from is science-based, it's factual, it's true? They're just saying there is a lot of disinformation out there on the internet, around things like vaccines, things like that. So what are your thoughts around, how you sort of put those guardrails in to ensure that the AI is only accessing information that we want it to? You look like you have some thoughts, Ryan.
I think this is actually an interesting new application for sort of the frontier and agentic sort of models. There's a whole lot of self-auditing sort of designs for some of these different applications and deployments. It's not just direct access to ChatGPT or direct access, unfiltered, unfettered, in and out. There's a lot more, as you saw with that Google sort of medical evidence explorer, another layers on top of it that are rechecking the output and auditing it and making sure that it has guardrails and that it's making sure that it's not providing information that it's not supposed to be providing, checking specifically for hallucinations, verifying verification mechanisms. This is sort of that next wave of maturity that we're going to see from these foundational models and how they're deployed.
Anyone else have any thoughts on that, on how we presumably, in many cases, it's about controlling the information that your AI tool can actually access. Marlene, within your Indonesian example, it's only looking at the records.
Yeah, so we as I mentioned before, we utilize our RAG model in terms of data that we allow the foundation model to access. So we actually send it pretty much, everything in the patient's medical record, and then we've got some guardrails in the back end to say only return data about the patient that is within the data profile that we send you. So don't make stuff up about a patient, and we've got some pretty strict guardrails at the back end to prevent the AI model from giving incorrect data about a patient. But that's just, I guess that's just one layer, Rebecca. The other thing that we have actually baked into the user interface is, the ability for the end user to verify and validate the data that's coming from the large language model. So we actually put in some a really easy way for the end user to access the charts that contains the data that the AI model has brought back. So if somebody says, give me the latest vital signs for this patient, and the AI would output that into the chat window, but also the user has a very easy way to access the vital signs chart, for example, so that they have and it displays side by side. So you have the traditional EHR user interface on the left-hand side that looks like a vital signs chart, and then there's the AI output. So it's really easy for them to validate that what data the AI is bringing back is actually true and correct.
And I'd also comment that I've seen underlying some of the models for AI scribes is that the transcript they send out to be interpreted, it actually has a pre-processing step that strips out identifying information, NHIs and things like that, before it goes out to the models, just as an extra layer of privacy, even though it's going into a secure instance. It's just making sure that there's extra layers built in like that. So there's a lot of that kind of technology circulating.
Yeah. CK, somebody's asked here, is there any work being done in Health New Zealand to enable AI to search past data sets to enable audit for quality purposes, saying that could be powerful? And another one that's, I think, wanting a bit more clarity around the trials or pilots specifically around medical imaging, because you mentioned general x-rays and
Sure.
CT heads. I just think
I guess with Gen AI and kind of our historical databases, quite a lot of our information is now being held within kind of cloud providers, sort of likes of Snowflake, and they themselves are starting to integrate Gen AI functions into that platform itself. So basic functions could be applied over existing data sets that's part of or on data that's within Snowflake. So that could be a potential avenue to explore. I think there's discussions around a couple of projects that are trying to achieve kind of the exact process. In terms of the radiology-based kind of, initiatives that's being planned for Health New Zealand, there are a few specific tools that we are wanting to kind of rapidly implement, assess, and evaluate. I think most of that will occur within the southern kind of districts, and hopefully work would just kind of start within kind of the next couple months, ideally. But I think it's still at the somewhat planning phase at the moment.
Right. Well, you have to keep an eye out on eHealth News for that one. And yeah, just in terms of audit, did just do a piece with Hata St. John about them using an AI for clinical audit of their patient records. So that's an interesting one as well. This is a very good question. They're interested in whether we've tested where liability lies. If a decision's made which are incorrect due to an AI tool being used. I imagine you're thinking hard about this when you've got a big organisation like Health New Zealand looking at implementing AI tools. got any thoughts around the liability issues?
I think it's one of those issues that I think is still outstanding, and there's a bit of disagreement around where exactly it lies. I think depending on which organization or which group kind of provides advice, it can kind of go in kind of two directions. What I typically see is a lot of the liability gets kind of placed back onto the clinician themselves, which I think from Health New Zealand, we think that is a little bit unfair, as the organization in which clinicians operate in, they will have a responsibility as well. So from Health New Zealand's perspective, we think it's the liability, it's kind of shared between three different parties, kind of the AI vendor themselves, the organization that's endorsing these tools for use in clinical practice, as well as the clinicians themselves.
Do you have some thoughts, Ryan? I presume in America, other countries must be quite different in terms of liability.
Yeah, I mean, America, there's always somebody. But I mean, there's certainly in America the liability is shared. If there's a bad outcome, everybody is named on the lawsuit. It's not just the individual clinician, but certainly the individual clinician right now, there's not a good way of sharing that responsibility. The Medical Council of New Zealand actually just put out a consultation about how should clinicians be responsible for AI and what are their responsibilities in this new age of AI. And they've had lots of feedback, and I'm not sure exactly where they're going to go. But it comes down to the way that CK framed it, the fact that you can't expect individual clinicians to be responsible for all the vetting and understanding all the foundational models and how quickly the technology is changing. And so it's going to have to be a shared responsibility between them and their institutions, and then the vendors that need to be trustworthy enough as well to be doing the vetting and providing the transparency and giving us the information we need to evaluate their products to make sure that we understand the risks that we're taking. And we know that nothing's risk-free in medicine. The medications you take over the counter aren't risk-free. But the model that CK described is probably the way to go.
Emily, you talked about responsible, InterSystems being focused on responsible use of AI. What are your thoughts around the liability and what happens if something goes wrong?
Well, this is certainly a very tricky question, Rebecca, especially for a global vendor like us, because we obviously have to comply with every single nation's or region's laws and regulations. Our eHR product is actually I think we're in about 25 different countries, but we only market IntelliCare in about 7 or 8. Before we open up a region or a country, we do have a compliance team and a clinical safety team who make sure that we have this product. What are the laws, rules, regulations, best practice guidelines in this country before we open it up to the market. So it's different for everybody. I guess that's the best way to summarize it. Myself, I cover the Asia Pac region, so Thailand, Indonesia, New Zealand, Australia, and there's varying levels of what people think. What people think constitutes liability in terms of using technology products, not just generative AI. So yes, it's different for everybody and different within different regions.
Yeah. Ryan, you talked about this thing called patient like mine. This one question's just saying, does this kind of amalgamation of information potentially contribute to groupthink rather than creative thinking in treatment protocols?
I think the purpose of this is for patients who are ideally unique, patients where the clinician themselves has little experience managing the condition potentially, or it's a rare condition or a rare disease where the treatment protocols are almost exploratory or experimental, and clinicians all around the country as distributed single minds could be floundering essentially. And this patients like mine that they're building into Cosmos is an idea that actually lets the physicians connect and have a discussion to each other by finding each other through the electronic health record and saying, I've got this patient that sounds a lot like your patient, and what has your experience been? So it's about sharing learnings. I don't think it's about groupthink so much as you say. I think it's more about connecting people and connecting expertise.
So what would you say, Emmeline, are the biggest challenges you've seen? You've obviously got your first implementation, but to adopting AI tools into clinical workflows, what are the things, the barriers that you come across?
I guess it's a change in the way that people access information, and to be honest, I've been implementing EHRs for about 10 years now. I think I just celebrated my 10 years at InterSystems, but I've never seen as fast an adoption of a feature within an EHR as I have seen with IntelliCare. People are really keen to use it. I guess the barriers is not at the clinical front end. It's actually an organization deciding that they will use an AI native EHR as opposed to a more traditional EHR, and allow their users to access that. We do have a product that allows users to just use the generic chatbot, and then allow more fine-grained control of which end users would have access to, the transcription services, for example. So we have that kind of flexibility within our customer base. There's very little barrier to adoption in terms of Gen AI. I mean, when we were performing just-in-time training particularly for our ED users in the emergency department, where we would just provide elbow to elbow support during training. And we would train a physician, for example, a particular ED doctor. We would actually have a crowd of people who were not training, looking over the shoulder saying, hey, how come I don't have that piece of functionality in my version of the AI? So it's certainly something that, everybody's keen to have a go at. And it's, because a lot of people now use a generative AI and are used to, things like Gemini or Claude or OpenAI, it's actually quite intuitive for them to use the chatbot to access information. And a lot of people tend to require very, very little training in how to use it. So yeah, the barriers, it's not going to be at the front end and not at the end user end, but it's going to be at the organization end, on whether or not, as an organization collectively, they want to be AI native.
And just finally from you, Ryan, what did you touched on it at the end of your presentation, but what do you see as the future of AI in terms of augmenting clinicians, or do you think it might actually replace some roles altogether?
I mean, I think some of it looks at the availability and the need of different health systems. I think there's a lot of latent demand for health advice, healthcare access, in a lot of different ways that could really improve people's lives. Whether it's support, mental health chat, or an semi-autonomous sort of, almost like a junior doctor that can come up with a plan and come up with a presentation and summarize a patient for you and for review. I think there's going to be a huge progression towards this semi-autonomous agent, and there's going to be a class of clinicians that will have to upskill on reviewing the plans and managing these sorts of almost panels of AI doctors to some extent. It's going to be a very interesting, and as Emmeline's talked about, a very rapid evolution for all of us.
Yeah, adoption and things are certainly progressing fast. So just finally, I'll give you the final word, CK. So looking ahead, how do you see AI changing the day-to-day experience of clinicians over the next 3 to 5 years in terms of your what you see coming down the pipeline?
I think if I try to address this kind of through the Gen AI and kind of the computer vision types of tools, I think with Gen AI, I think the ability to kind of reduce kind of administrative burden, I think with the tools like AI Scribe in the near immediate future, I think those sort of tools would definitely address some of those administrative burdens. But there was still that potential for it to address kind of other use cases. So or kind of also within that kind of documentation workflow, but it's also trying to retrieve other sources of information. How do you get clinicians to find the right information at the right time with kind of the shortest amount of effort? I guess when it comes to computer vision, I think that's more that will be an area where you'll probably see more automation of some certain things. So those algorithms, their ability to identify certain conditions, or if it's the ability to understand if this image is normal. Once we get that confidence to say that technology is going to work, the ability to try to remove or reduce kind of human double human checking of some of those conditions, some of those exams, I think that will reduce in the future. So I think potential quite large in the future. Just trying to get there. It'll be a bit of a challenge, but I think the outcome will be great.
Mm-hmm. Great. Well, thank you so much to all of our panelists. What a fascinating discussion. Unfortunately, we have to wrap it up. We haven't managed to get to all the questions. A couple of them are just asking for sources of some of the examples given around the risk priority scores, and somebody's asking for the Kenya GPT trial information. So anyone who's asked for those things and have included your email address, we will try to come back to you after the presentation. Cool. So yeah, just falls to me to thank once again the panelists. Thanks to InterSystems for sponsoring such an interesting topic, and thank you to our viewers for joining us today and supporting HINZ. If you're not already a member, you can click on the HINZ logo at the top left of your screen or go to hinz.org.nz. Mā te wā.